Hello, Assalamualaikum. My name is Amory, and I'm the representative of the student group discussion B9. And today we are going to present about esophageal varices. Our group members: Winnie, Eka, Justin, myself, Amory, Christian, Harmyta, Kylie, Sherly, Lordia, Meidy, Steffi Ayu, Yuma, Joshua, and Clara. Please enjoy our presentation. Thank you.
So hi, my name is Ardelia Clara Budiman with last year number 234. So today I would like to explain about esophageal varices background information. So esophageal varices is when the dilated submucosal distal esophageal veins connects with the portal and also systemic circulations. So this is caused by portal hypertension, resistance to portal blood flow, and also increased portal venous blood influx. So a normal portal pressure will be between 5 until 10 millimeters of mercury, but due to the portal obstructions, the pressure increased, and it could reach as high as 15 until 20 millimeters of mercury. And since the portal venous system has no valve, the splenic arteries and also the right side of heart could ended up causing retrograde flow with high pressures. And when these pressures grew bigger, it will lead to serious hemorrhage. So that is why an early interventions are very necessary and needs to be treated quick and also appropriately to prevent more harm to the patient's body. So that is it from me. Thank you very much.
So this is our problems formulation. There is what is the epidemiology of esophageal varices. There is what is the anatomy of the esophageal varices. Then what is the pathophysiology of esophageal varices? What is the etiology of esophageal varices? What is the diagnosis of esophageal varices? What are the prognosis of esophageal varices? And what are the treatments of the esophageal varices?
Okay, my name is Mahadevi Dewi Febriyanti with the last 3 digits student number 143, and I'm going to explain about the objective of this student project. For the general objective is to improve the understanding of esophageal varices. For the specific objective is to explain the epidemiology of esophageal varices. The second one is to explain the anatomy of esophageal varices, and then to explain the pathophysiology of esophageal varices, to explain the etiology of esophageal varices, to explain the diagnosis of esophageal varices, and then to explain the prognosis of esophageal varices, and the last one is to explain the management of esophageal varices. Next.
Hello, my name is Christian Salomo Parasian Sinaga with student ID number is 096. So I'll tell you what the benefits of our article right now. So we have two benefits right here. One of them is practical benefit that it is hoped that this article will give lots of information about varices esophagus so that people could know about this condition and became aware of it. And the second one is theoretical benefit that the writers hope that this article will give information that could be used in another research. And the writers hope that also this article will be useful for the medical students as their reference to study about this condition. Next.
Hello everyone, my name is Joshua Francisco Syofyan with the student number 20025112229. Today I will explain the epidemiology of esophageal varices, which are more like, esophageal varices are more likely in male patients and also are found in 30% of cirrhotic patients. They also have a 1.8% chance of developing into upper gastrointestinal hemorrhage or UGIH with a 6.1 per 100 cases mortality rate, which is one of the highest mortality rates of upper gastrointestinal hemorrhages compared to other etiologies. Next.
Hello, my name is Lordia Lin. I'm going to continue the presentation. I'm going to talk about the anatomy of the esophagus. The esophagus expands from the pharynx to the abdominal following the vertebral column concavity. It extends almost as long as 25 centimeters long with a diameter of 2 centimeters. It is a duct of round and external longitudinal layers of muscle that is mostly compacted posteriorly and anteriorly. It inserts amid the trachea and the vertebral column to the upper mediastinum, where it is on a line with the vertebral bodies of T1 to T4. The abdominal part of the esophagus receives vascularization from the esophageal section of the left gastric artery, and the venous drainage are mostly to the portal venous system through the left gastric vein. On the other hand, the superior portion of the esophagus in the thorax cavity drains mostly through the esophageal veins into the systemic venous system. The esophagus is innervated by the anterior and posterior gastric nerves that originates from the vagal trunks, also by the abdominopelvic splenic nerve that derive from the thoracic sympathetic trunks. Also, the esophagus is innervated by the periarterial plexus. Next.
Hello everyone, my name is Kylie Wingel and now I will continue the presentation about pathophysiology of esophageal varices. So chronic liver damage or liver cirrhosis patients have an abnormal wound healing response which substitutes the hepatic parenchyma into fibrous scar tissue. The changes of hepatic parenchyma into fibrous scar tissue happen continuously, leading to the increment of portal blood pressure. Therefore, blood flowing to the systemic circulation has to go through additional pathways that bypass the liver, which could cause the enlargement of the capillary veins and esophagus, known as esophageal varices. Okay, that's all from me. Thank you.
Hello everyone, my name is Mita with class 3, student number 111, and today I'm going to explain about the etiology of esophageal varices. As we all know, esophageal varices are enlarged veins in the esophagus due to liver disease. These can sometimes cause obstruction to the blood flow of portal vein. There are also causes of these esophageal varices, which can be divided into 3 parts. The first one is prehepatic, which is portal vein thrombosis and massive splenomegaly. The second one is intrahepatic, which is congenital hepatic fibrosis and idiopathic portal hypertension. And the last one is posthepatic, which is inferior vena cava thrombosis and constrictive pericarditis. There are also uncommon causes, as we can see here, which is Wilson disease, alpha-1 antitrypsin deficiency, primary biliary cirrhosis, tuberculosis, and the last one is constrictive pericarditis.
Hello, my name is Frastika Sari with 3-digit class number 052, and today I will continue about the diagnostic. Esophagogastroduodenoscopy or EGD is considered as the best diagnostic method for esophageal varices. And alternative diagnostic are ultrasound, capsule endoscopy, barium radiography, portal venous angiography, splenoportography, and manometry. In EGD, after endoscopy, the imaging can be graded with several classifications. In Paquet classification, esophageal varices can be classified according to the number, location, and caliber, which can be seen in Table 1 and the endoscopy imaging in Figure 1. In Grade 1, microcapillaries are located in distal esophagus or in the esophagogastric transition. In Grade 2, 1 or 2 fine caliber varices located in the distal esophagus. In Grade 3, medium-sized varices of any number that may reach up to a medium third of esophagus. And Grade 4, large-sized varices in any part of esophagus, cherry red varices overlying the large, slightly deeper lying, slate blue-gray varices, and it's also known as varices over varices. And this is the endoscopy imaging in esophageal varices.
My name is Winnie Chandra with the last 3 digits of student number 027. Today, I'm going to talk about the prognosis of esophageal varices. Esophageal variceal bleeding is a serious condition that can be life-threatening. Most deaths occur within a few days of bleeding, and the mortality rate is higher in the context of surgical intervention and acute variceal bleeding. People who have experienced episodes of esophageal variceal bleeding have a 70% risk of rebleeding, and 30% of the rebleeding episodes can be fatal. Recurrence of bleeding can be reduced with medication and lifestyle changes. Treatment with variceal ligation is said to be effective in controlling the first bleeding episode in approximately 90% of patients. However, nearly half of individuals who have had variceal ligation will have another rebleeding episode within 1 to 2 years.
Hello everyone, my name is Septiana Chandra with 3 last digit of student number is 129, and now I'm going to explain about the management of esophageal varices. The goals of the management of esophageal varices is hemodynamic stabilization, minimal complication, and effective therapy for the patient. The management is divided into two, the pharmacology and the non-pharmacology. The pharmacology treatment is to lower the pressure of intravenous and portal vein. One of these can be given to the patient. Terlipressin, octreotide, non-selective beta blocker or NSBB, and carvedilol. The non-pharmacology treatment is to find the source of bleeding and stop collateral blood flow, and the non-pharmacology treatment is more effective than the pharmacology treatment. The non-pharmacology treatments such as endoscopic and variceal band ligation. That's all from me. Thank you.
Hello, my name is Steffi Ayu Soejanto with real last name number 163. Here I will present about the conclusion of our student project. So, esophageal varices happens when the submucosal distal esophagus veins are enlarged abnormally. Epidemiologically, males are more likely to have this condition than females. The most common cause is always related to chronic liver damage. Esophagogastroduodenoscopy is the gold standard to diagnose this disease. The pharmacology treatment itself can be done by giving intravenous terlipressin or octreotide or NSBB and carvedilol, while the endoscopic treatment works effectively as the non-pharmacology treatment. Thank you. Next.
Hello, my name is Kylie Wingel Mahadevi with student ID number 20025111189. I will continue the presentation about suggestion. So because esophageal varices is a life-threatening disease, preventive measures are needed to prevent this disease. Some preventive steps that can be taken are to avoid unhealthy lifestyle that can trigger liver disease, such as avoiding alcohol consumptions and preventing infections, especially hepatitis. Education to the public regarding the dangers of consuming excessive alcohol is also important, and the government is expected to pay attention to the prevention of esophageal varices through its policy on liquor. That's all from me. Thank you.
So this is our reference. And that is all for our presentation. If we said anything wrong or we pronounce something incorrectly, please forgive us. Thank you.